So I want to do some disclaimers. I don't have any industry conflicts of interest or anything of that sort. But I also want to tell you I'm really not an expert on suicide prevention. If anybody tells you in the world that they're an expert on suicide prevention, then they have Pinocchio disease. You know what happens, right? So, because we have never, ever seen systematic, well-planned, effective, demonstrable efforts in suicide prevention, with a very small number of exceptions. And so I really want to put forward this talk as something of a thought piece and ideas, something to really open the door for conversation and controversy. This is not one of those issues where I have all the answers. I've certainly thought about this for a long time. I've certainly done a lot of things. But to say that I know how to take the increasing suicide rate in the United States, which has gone from 10.48 per 100,000 in 1999 to 13.02 in 2013. That's nearly a 30% increase. In some groups, it is a 30% increase. And to say that I know how to turn that and bend it down and do it in a systematic fashion would be misleading. So it's in that spirit of we're in this together and we're going to work on this together that I sort of present this thought to you. Now, winnable battle is a term of art that comes through CDC now, and the director of CDC doesn't list suicide prevention as a winnable battle. In fact, CDC, although we have funding from CDC, doesn't list suicide as one of its priority areas. And we had to sort of prove it to us that it's a priority area, that there's a significant burden. I'm in New York State. The New York State Department of Health doesn't list suicide on its website, even though you can dig in and find it. And I'm giving them a hard time repeatedly for it. I'm not shy about expressing my point of view. So I'm going to talk about these things today, share ideas, and understand that we're all in this together. I've been thinking about this since fall of 1966, before most of you were born, when I was an undergraduate student at upstate New York school with lots of high gorges. If you just can't, that's Cornell. And people jumped into the gorges and I didn't get it. I didn't understand. I had, in some sense, an absence of empathy. I was sympathetic, but I couldn't put myself into the idea that I'm going to heave myself off this bridge. And I walked over several of those bridges, one of them every day, to go to campus. And so I did what I often do when I don't understand something. I thought about it, and I read about it. Sometimes I read before I think, sometimes I think before I read. Supposedly you're supposed to do the same, the two together, but that doesn't always happen with me. But in any case, then I started trying to understand this more, and that's really led to sort of a path where, certainly since the 1980s, I've been actively involved with a group of really talented people. Well, it's grown, so it's now a rather substantial group of talented people, but not only in Rochester, but around the country and around the world. So this is a big public health problem. And it's while I'm a trained psychiatrist and chair of the Department of Psychiatry, and was an inpatient hospitalist, if you would, the first in Rochester at the University of Rochester Medical Center, and took care of many suicidal people. And my two favorite places to work, it shows you how bizarre I am, were the emergency room and the inpatient service. And we all, as physicians, pick our places, and I sort of found it very hard to sit still doing a sort of traditional psychotherapy. I think I was probably more restless than most of the patients I treated. I still had the chair where I could hold on to the arms so I wouldn't move too much. And it's not because I actually have a movement disorder. But in any case, this is a public health rationale for suicide prevention. And it's very straightforward. Most people who die by suicide are not seeking help. I never use the word gesture because, suicide almost always is an ambivalent act. And some so-called gestures are entirely fatal. And people sometimes with great intent survive inadvertently. So it's really the notion that people who, over and over again, you see them, he seemed okay. I didn't know anything was wrong with her. you know, yeah, there was something going on, but that's usually the case for him or her. So very hard to recognize. And we'll talk about the fallacy of risk factors. That isn't to say that there aren't things that make people's lives more adverse, but to use them as warning signs, which has really been promulgated in the United States, turns out to be a trap, which is very misleading. And ultimately, we want to do something that is really akin to heart disease. In heart disease, you know, we tried to build intensive care units, and 10 years later found that it didn't change at all the mortality rate from heart disease in the 60s and 70s, because people died before they ever got to the hospital. And it's really been in the last 40 or 50 years where we've learned that what we want to do is change the trajectory of people's lives by having them not do certain things 10, 20, 30 years before, so they never come to the point where they have an acute heart attack. We want to get to the point where someone never has an acute suicide attack. Now, this is very difficult because most of suicide prevention to date has been thought of working with a suicidal individual or the survivor of an attempt. It's very hard to build coalitions about going something 10, 20, 30 years out. But I'd say changing childhood adversities, affecting intimate partner violence, dealing with elders who have untreated or poorly treated pain, medical systems diseases. These are the kinds of things that we have to think about, even as we also think about the person who's at the edge of the cliff. So, I'm going to say these things and then say it to you again. If we don't collect data and we don't look at that data, we're going to fail. If we don't monitor what we do, we're not going to understand what works. It's not, the expression is, it's not what you expect, it's what you inspect where you will make a difference. And very clearly, just because something seems like a good idea doesn't necessarily mean that it's going to change anything. One of the things that we know about gatekeeper training, for example, is most gatekeeper training programs, you know, this so-called giving someone an hour or two of education saying that they're going to change their behavior. People don't change their behavior. If you think what it takes to talk to someone who's suicidal and think that, oh, if I give you an hour introduction, you're going to feel all that more prepared to sit down and talk with somebody about why he or she has decided that it's time to end their life. It doesn't happen. It takes skill and practice in order to do this. It takes some sense of support, some sense of rehearsal. We don't get people to change very quickly on anything. I mean, physicians, if you think about physicians, are the hardest people to do continuing education. You know, there's all this plasticity of the brain during medical school. It starts to reduce during residency, and by the time you're intended, take it from me, you know, your brain plasticity is turned into bone. It's very thick. So, in any case, as we can see, the suicide rate in the United States hasn't gone down particularly over the last 50 years, and indeed, since 1999, it is scaled upward in a consistent fashion. And certainly during the Great Depression, there was a high suicide rate. And now we're knowing very clearly during the Great Recession, there's been a rapid increase. And colleagues and I do research on the relationship of economic factors to suicide. And one of the important lessons of this is that context matters. It's not just about the individual. It's that person in the context of family, community, the society. And how you integrate those different levels is a very challenging aspect, which we'll come back to. And of course, for me it's of course, but for most people it isn't. The burden of suicide in the United States is in the middle years of life. It's not used. As you can see, under the age of 19, the suicide rate is very low. It starts to course upward after that. It then becomes very high in the middle years in terms of the burden of disease. Now, suicide in the middle years has a higher rate than suicide in late life overall because it goes down in women. It still goes up in old white men. All the old white men in this audience, be careful, you're part of that list. I'm included. But on the other hand, that's a smaller denominator. And the driver of suicide increase in the United States over the last 15 years has been suicide in the middle years. It is fair to say that none of our programs around the country focus on this population. There are political and social reasons for this, but it's very clear that we will never change the suicide rate in the United States unless we focus on the middle years population. And this is the standard figure on rates. And of course, rates don't tell you just about numbers, because obviously numbers depend on the numbers. Now, North Carolina. I figured I'd give you some North Carolina stuff. North Carolina has managed to stay higher than the United States over all these years. So in 1999, it was 12.88 when the U.S. was 10.48. And in 2013, North Carolina was 14.94 suicides per 100,000. Age adjusted was a little lower. So North Carolina has suffered a somewhat higher burden. If you dig in, you see that it's in the middle years. I made sure to put those in red. Now we can see 25 to 29 as a surge group here, but really consistently, it's in the middle years of life. Men have almost 4 times the suicide rate as women. That's consistent with what we see in the United States. So North Carolina, in some sense, is very much a copy or a leader. It's not the highest by any means, but it certainly has a very substantial suicide burden, which now is the leading cause of injury death in the state. So this is from the Mortality and Morbidity Week in Review and from a May 2013 paper, and it shows the increase in men, somewhat in firearms, a lot in terms of suffocation. Suffocation is mostly hanging, but it's also kind of putting a bag over your head, and either cutting off the air or putting helium in the bag or something of that sort. So it's gone up steadily over the years in men and in women, although for women, the issue has really been more of the increase in medication-related drug poisoning. But also suffocation. Clearly, though, you're going to be faced in North Carolina and every other part of the country with the question of who's the focus for mental health care and who's the focus for prevention. Now, in the mental health world, right, we tend to focus on the severely distressed, people with schizophrenia, people with bipolar disorder, people with very severe major depression. But individuals showed many years ago, for instance in Great Britain, England, that if you focus on, say, major depression and people coming out of hospital, that you would only modestly, if you reduce the suicide rate in that group by 50%, not likely, nonetheless, if you did, you'd have an impact on the overall suicide rate of the country of about 10%. Because most of the suicides come from the general population. Most of the suicides don't come from the people who get seen in, like, my department of psychiatry. One of the reasons that I switched, along with colleagues, to a public health approach was we worked with a medical examiner. We're doing psychological autopsies from the mid-'80s to the mid-'90s. And by 1995, we realized that all our views that, we can just shove everybody into the mental health system were total fallacy. Totally misguided. Elders, by and large, didn't want to go see psychiatrists. Many people who had seen them had dropped out of the system months or years before. Certainly many had seen primary care providers, but a lot of people were just, more in the courts, more in the criminal justice system, in jails, in communities. And we started to have to say, well, where will we find these people? How will we engage with these people? These are the questions that started to really pose themselves to us. And we started to think about the public health world and really took to heart something called Rose's theorem. Jeffrey Rose was a cardiological person who wrote about public health theory. And he pointed out about heart disease and other things, that it's really the big population, even though there's much lower risk, that ultimately contributes more to the overall community mortality than the high-risk disease population, because the community has a much, much, much bigger population denominator. And for something like suicide at night, you start to begin to think of the population distribution. And you say, well, there's a mortality threshold, and I think by basis of risk, people are, I'm going to pay attention to this high-risk group. And they're going to be much above it, and then the general population has a much lower risk. take this diagram, and then we'll come back to it as sort of an illustration of the different approaches and where we think this is going. So, there are what I call 5 challenges which pose themselves to us as we think about suicide prevention. The first challenge is we don't know how to discriminate the relatively few true cases from all those people who we can call false positives. So we might say, I'll give you this as an example, major depression. So we might say that major depression, clinical psychiatric disorder, buys you antidepressants, gets you to see not only mental health professionals, but psychiatrists, might get you to the inpatient service or the emergency room. We might say that that has a suicide rate that's, almost 50 times higher than the general population. So right now the general population is 13 per 100,000 in the United States, which means that if I saw anybody in the general population just on the street, and I walked up, of course they'd look at me rather weirdly if I said, well, you have a 99.9% chance of never dying by suicide. Or at least not this coming year. I'd be right. With the population of people with major depression, let's say it's 600 per 100,000 of clinically depressed people. That means in that group, there's still a better than 99% chance that they won't die during the coming year from suicide. But we use this as a big risk factor to segregate out the group and say, oh, we've got to pay a lot of attention to it. Now, there's a difference between saying someone deserves treatment, which they absolutely do. If someone has major depression, there's no question that this person needs treatment and intervention because it's a very, very painful, disabling, functionally impairing condition. But that's very different than saying treating everybody, if I could, will really be a suicide prevention. And the field has conflated the two because we understand that in the past 75 years in the United States, suicide was viewed almost exclusively as a mental health problem, and not as a community problem, not as a public health problem, not as a social problem. But you go to different parts of the world, it's a social problem. You go to Japan or Korea, for example, and there have been tremendous population transformations and economic development, relocation. And people will tell you that, for instance, the elder family that feels abandoned because their son or daughter or children moved from rural Japan to urban Japan, or rural Korea to urban Korea. And now they have no social support. And they still have all the, the family belief structure of a Confucian society, just not the reality of that. Then sure, the final common pathway may be depression, but part of the factors that generate into it may be economic transformation and social values and beliefs, in the same way that economic factors we know contribute to suicide. So this approach has real challenges to it. But this was the notion of an indicated preventive intervention. And for those of you in public health, there are indicated, selective, and universal interventions for populations. And so the idea is to identify and treat the high-risk people. That's what this is. There have, suffice to say, this has been very hard to ever show that it actually changes suicide. Now, there are a couple of examples, and I'll talk about that in a minute. Selective approaches, similar, is to target what we might call a high-risk group, where we know that somebody in that group is much higher risk, but we don't know which person. So, for example, someone who's detoxing at an alcohol treatment center. That group, the alcohol treatment center group, would be a selective population if you chose to focus on it. Now, we choose, as I'll tell you about, to focus on people who come through the courts and the criminal justice system and think of those as public health settings. Well, that's selective intervention. Now, there are differences between selective and indicated preventive interventions and clinical treatments. Now, in one case, I'm saying I'm going out and getting a group of people who are coming out of alcohol treatment. It could be other kinds of areas where I'm actually going and finding them in communities, as in courts. So public health reaches into communities. It doesn't wait for people to come to the clinic. Now, this is a really interesting issue because in psychiatry, you're often taught, well, someone shows their motivation when they come to the clinic, and that's the real sign that they want to get changed. And that's sort of So if they don't show up, that's their problem because they're obviously not motivated. You can't do psychotherapy on them. But think about this if you were running an STD clinic. I'm going to wait till all the contacts on their own come waltzing in to tell me that they happen to have contact with this person, but they actually didn't know that they had gonorrhea or something. In a public health way, we reach out, we go into communities, we engage people where they are. There are a whole array of ethical issues with this too, but nonetheless. And when we do community work at its best, it's co-owned by the community. It's not something that we just go impose ourselves. It's something where we build engagement, where we build a sense of collaboration, where the community, and we'll talk more about the necessity of this, feels a co-ownership, a partnership. So, preventive and selective therapeutic interventions, or whatever we want to call them, for people with so-called risk factors are really important and desirable because people need disease that's treated, right? If you've got a flu epidemic, you're not going to say, well, we only do immunization. We don't do treatment of acute disease. If someone's got pneumonia and has developed a secondary infection, of course we're going to treat it. But we know that treating the acute disease of the flu isn't going to stop the spread of a flu epidemic. We have to do public health work. We've got out in the communities and do immunization. So it's not really been demonstrated at a wide scale. I mean, there are some psychotherapies, behavioral therapy for people with borderline personality disorder. One study where somebody sent out caring cards. Another study by WHO, which is a little bit more problematic. It's not clear that it's a real result. It got published, but it's nonetheless uncertain. So there have been a couple of small studies, but nothing that really says, yes, we can make a systematic approach to the bigger problem of suicide. Challenge 2. A lot of people never tell you. This is very, very common. We didn't know, and early on we were taken with a number of people who had been seen by their primary care physician in the last week, sometimes the last day of life, especially elders. And I thought, wow, maybe these docs have bricks made out of heads made out of brick at this rate. Well, brick and head, ceramic capability, doesn't resonate much, low on sensitivity. So I got, because we worked with the medical examiner, I could get all the records. And I reviewed all these records. It was very clear that the docs often asked just the right questions, and the individuals were not revealing or forthcoming. And then when we started talking to the families, we realized they were not revealing and forthcoming. Many, many, many people are not revealing and not forthcoming. Others have turmoil-filled lives, and how can you tell that today is the day that someone feels suicidal versus yesterday or last month or last year when they were just in a family argument and fight? It's sometimes impossible to tell. So this is where we talk about universal kind of preventive interventions, where you have large populations where you can't recognize, but you try to make changes so that it doesn't necessarily depend on individual action. And so the idea is you drive the whole population to the left in this figure. Or, if you can't do that, at least you change some of what we might call their default decisions. So that when they make a decision to die, it turns out that it's not so lethal. So, example. This is from the UK, and this was one of the times where it was very instrumental, active attempt to change suicide. They removed, or at least they were thinking about it, they systematically, from the 1950s to the 1970s, removed carbon monoxide from the domestic gas, the cooking gas, which had become the primary method of suicide in the UK. And this has now been known elsewhere. That's the percentage. What you can see on this slide in the red is that the suicides from carbon monoxide gradually dropped, and the overall suicide rate dropped over that period. Eventually, people came up with substituted methods and it went back up. But in the interim, they estimated that 5,000 to 7,000 lives were saved. So this was a preventive intervention that is very much like the notion of airbags. Airbags are a universal preventive intervention that does not take the compliance of the person. Now we know that seatbelts are as effective or maybe even more effective than airbags. But the installation of airbags as a public health tool to reduce motor traffic injury deaths, notice I don't use the word accidents, was a really critical issue, critical innovation. We haven't done that with suicide. And of course, and we'll talk about it, there are limitations in our country. So, means restriction is a universal approach. It has been shown in multiple settings, not necessarily nationwide as in the UK, but certainly in settings where they've changed pesticides. An example right now, although we don't have the specific data, one of the reasons that colleagues and I started working in China is because the suicide rate in China was much higher in women than men. And when we looked at it, it was in rural women. People had all sorts of sociological explanations, but the research, including some of ours, in rural communities does not suggest that the suicide attempt rate was any higher in rural women in China than it was anywhere else in the world. But they used the available means, which were first-generation agricultural pesticides and first-generation organophosphate pesticides, for those of you with some medical background, are exceedingly toxic. And so what have they done? They've substituted second and third generation pesticides, improved their emergency services. It's not clear at all that the attempt rate has gone down. What is clear is the death rate has gone down. Because one method is not the same as another. I was in Ithaca, New York, when there was consultation about a spate of jumping suicides in 2010. By the way, Cornell doesn't actually have a higher suicide rate than other places. But it certainly does have a higher public suicide rate. So publicity makes a difference at times. But over the course of 20 years, its suicide rate is comparable to other universities. But in any case, one person said to me, well, why are you going to put nets up? It's going to ruin our aesthetic. And if they're going to do it, they're going to do it anyway. Now that turns out, A, to be incorrect, because people often choose their method, or the method chooses them. We'll talk about that in a bit. And we don't understand that, but if you prevent someone from using one method, they may entirely not go on to use it. But I pointed out to him, I said, look, if I can get this person to switch from jumping off one of the bridges, my neighborhood bridges, to taking a bunch of pills, I know that I'm going to go from a 95% or 100% mortality to about a 3% mortality. That's a public health win, even if I don't change it at the mental health level of about 10. So it's putting these together which becomes really important. But in the U.S., we know that the political issues about firearms, very hot issues. So we have to find a different language. Some of us are talking about a culture of safety. Now, a culture of safety can extend not only to firearms, but to pills, to, in a public health way, to throw rugs that elders fall on, to how do you protect your little kids. Can we have a culture of safety which reaches out, not just for suicide, but to homes and communities in general? Is this an area we can build alliances on? Third challenge, really important, which is that you may have really wonderfully talented mental health professionals and clinical professionals, but there's a mismatch between where the potential clientele of patients would be people and where the clinicians are. Most clinicians live behind rather high walls, and if any of you try to go to a medical center or doctor, you find that it's sometimes hard to break in, right? Now that medical centers in the last 10 years are becoming customer-oriented, so they make it much easier for you to break in to get care. But sometimes it's felt like, I got to sit 4 hours here, go 3 hours there, go from place to place to place to place. That's not the way you're going to run a prevention program. We have to find out where people live, and we have to deal with it. So I think of this in two conceptual ways. Every community has a social geography. And these are the places that we go to find people. Now, every site has a sample bias. People you want to find, and also people you're going to miss. So if I set up a suicide prevention program in school, whatever the kind of program, in say a high school, I'm going to miss all the kids who dropped out. And some of those kids are in fact going to be the most important kids for me to try to engage with. The ones who are already in trouble with the law, the ones who've had 4 or 5, 6 childhood adversities, the ones who are kind of on the margin, using substances or selling them or all the above. If I go to universities, right, which has been an intensive setting for suicide prevention work, I know 2 things. Number one, the suicide rate among university students is probably about half of their community peers. And number 2, I'm going to miss all the community peers who don't go to university. Number 3 is I tend to go to big universities with 4-year students, but a huge number of students are in community colleges where they don't have these kind of programs. So, again, who do you capture, who do you miss? You go to an organized work site, you'll get some people, but you won't get the migrant workforce, you won't get the underground people, you won't get the unemployed people, you won't get the people who just lost their job. And on and on and on. So every interesting and important setting has a people I capture, people I miss. Now, governmental settings, including courts and criminal justice system, very rich environments for seeing high-intensity populations. A couple of examples. Some of my colleagues did a study where they asked women who were putting out orders of protection whether the respondent, you have the petitioner and the respondent, the person who is on whom the order is served, whether the respondent had attempted suicide during the year before. And 100 women said 12 of their respondents had. Now, in the DV community, and we work a lot with the DV community, a lot of people said or would say, well, these are totally manipulative. I'm threatening suicide so you don't leave me. But they're also sometimes fatal. And the issue that they could at once be manipulative, underhanded kinds of actions from someone who's been a victimizer, from someone who also may have been a victim early in life, to try to control someone else, doesn't mean that they won't actually go kill themselves. One of my colleagues, based on this, did a study, actually took out some old psychological autopsy work that had been published in the early 1980s and went back and found that 50% of the men between 21 and 49 in that sample had been in domestic violence situations where they had evidently been the perpetrators. So, being a perpetrator, being in some sense an unsympathetic person when seen by many professionals, doesn't mean that you're not going to go kill yourself. And so, as professionals, we're challenged with how do we reach out to someone like this, even as we're confronted with the fact that they can be somewhat unsafe. Social media has become a tremendously important tool that we're using for research, because there are a lot of populations that are on social media that are not easily aggregated. So, for example, several of our pretty broad group work with the Trevor Project, which is out of LA, working with LGBT youth. We're right now trying to figure out who populates the adult gay LGBT community, because we know that suicide goes up tremendously, right, but into the middle years. There's been no work in the United States, none, on suicide in the middle years in the LGBT community. And how do you reach them if you can't find them? And we're talking about a generation that didn't necessarily feel so comfortable in saying, hey, I'm out here, I'm in the world, I'm deserving of your attention when I have a health problem. So this is a challenging area to try to contact hidden populations, but populations that we think have really high burdens of disease. But again, another community, who do you find, who do you miss? Of course, you may be interested in specific populations. And so another way of looking at communities and saying they're not in my clinic, but they are somewhere, is to think of what I call social ecology. Where are they? Where could I find them? If I wanted high-risk dropout youth, I'm putting dropouts in quotes on this, where would I find them? Where are the places that I have to go in order to engage them? So in our Department of Psychiatry, which again makes us somewhat atypical, we have a whole array of community-partnered programs. There's the jargon out of NIH called community-based participatory research. Now that came out in 2004 or 5. But we started working with the medical examiner in the 80s and started doing things with the community in the 90s, and then started an office of what we call mental health promotion in 2004, because it's all outside the walls, not just inside the walls. And in fact, if you want to make it so that someone never comes to your emergency room as a failure of the system, then you have to build your systems outside. And Rochester is one of the poorest cities in the country, despite the wealth of Monroe County. There's a tremendous dichotomy and segregation on the ground because people moved out and how the city's coalesced itself. And so, there are many parts of the community that have very little infrastructure, while other parts, have tremendous infrastructure. So you have to really think about how am I going to find these groups across very diverse boundaries, and they are boundaries of groups. And again, you can make populations for youth, people with severe mental disorders, people with substance use problems, depressed folks, elders, suicidal people who have been identified as suicidal. Everywhere you can say, I can track their paths. Now, then what I basically say is that suicide prevention starts to come together as a mosaic. And the mosaic is really multidimensional, right? A mosaic is a picture where when you look at any one piece, where you look at any one color or little square or whatever you want to call it, it doesn't make a picture. It's when you put them all together that you see the picture. So some of this mosaic then is beginning to involve things like what kind of program, is it universal or selective or indicated? Some of it is how do I reach out or set up things for people who I actually never see and can't recognize universally. Some of it is what are the settings in which I have access to and who do I capture or engage, who do I miss? Some is where would I find the people that I'm really looking for? So these are really how do I put this together in a dynamic way that is really tuned to my space, my place. Upstate New York and North Carolina aren't going to be the same. New York City and upstate New York are radically different. Although I have to sometimes remind people in New York City that they're not all in New York State. These are tremendously variable. And when you want to go build a partnership, I'll move to the next slide, but when you want to go build a partnership, sometimes it takes 2 to 3 years. I tell junior faculty who are beginning their careers, think of investing 24 to 36 months in building this partnership. Now, we've speeded along. Our shortest track record is 18 months because one of our former fellows had retired from the university and was working in the school system, so he helped smooth the way. But it's almost universally. I started talking with the Air Force in 1998. It took to 2000 before they sort of agreed that we could really sit down and really start talking about it. It took another year when I introduced someone who was a mentee of mine. She's much taller now. She's still this tall, but she's and she's really become the expert working with the Air Force. And this has gone on now for 15 years almost, but it took 3 years to get that ball rolling. Very typical. Whether it's elder stuff, kid stuff, whatever. Fourth challenge. We really don't know what leads to suicide. We have our theories. But these theories are psychological, they're biological, they're social, they're cultural. We don't know how they come together, that most of the people, the vast majority of people who are under the pressure of what is going on in their lives, 99+%, never go on to die by suicide. What protects them? We have very little understanding about protective factors. We're trying to do a study right now in collaboration with people in Turkey and Korea. Turkey has a remarkably low suicide rate. Undergone tremendous economic transformation. 75% of the population is urban. It's a Muslim country, but it's, lots of political tension. Some parts are very observant, some parts are very non-observant. Korea has either the number 1 or number 2 suicide rate in the world. It's gone up radically in the last 20 years. Both Korea and Turkey espouse very high, coherent, cohesive family structures. Much more so in their philosophies and their belief systems in the United States. The United States is sort of intermediate. What is the relationship between what we're calling communal coping and and family values, and, as well as suicide. We don't know the answer yet, but we're hot and deep in this. How that informs what we're doing. We don't know what's protected. And there are many patterns across the United States. I'm just showing one. This is the geographic distribution of suicide in the United States. How come? Now, some people have argued it's just firearm availability. But I know that or someone said handguns. Firearms are all over the place in upstate New York. You know, it's a big hunting country. And yet we have a very, very, very low suicide rate. Now, yes, it's hard to get a rifle like that, but people do it if they want to. So this is more than just handgun availability or firearm availability, because this pattern gets replayed in motor vehicle injury, except for California's a little higher. Here's another one. This is about, this is domestic gas in the UK, England and Wales. This was firearms and others. So in the late 1800s, domestic gas becomes very available. Men are the early adopters. You know, for all you women who think men aren't flexible, I just want to tell you that men are very flexible when it comes to picking up new methods of suicide. So men were the early adopters, and then women followed, and eventually it became the predominant form of death in the UK. Suicide, gassing oneself. The Sylvia Plath, for those of you who remember that person, and put her head in the oven. That was the common method. How come it changed? And then, of course, here's the reduction I talked about. They went back up because they switched cars, and then the next reduction was the introduction of catalytic converters. So catalytic converters became a very important suicide prevention. Here's a more modern example. This is from Hong Kong, and I'm in the et al. Territory on this paper. And we did some more work in Hong Kong. But right here, is the introduction of charcoal burning. So, hibachi, charcoal, stick your head in the hibachi, breathe in the carbon monoxide. No cases. Then in 1998, 4 cases, but tabloid newspapers in Hong Kong have basically room diagrams, how-to diagrams on how to do this. And 4 years later, it's 26% of Hong Kong suicides. Now, not everybody did this. It was picked up primarily by people in the middle years of life, the working age, and by men. Women came along later. And there was really no method substitution at the time. Very little bit among women. Eventually it came down, and it's now become part of the sort of the mix in Hong Kong. How come this new method selected, in fact, what appeared to be a new group of people, or at least extra people, during this time of economic turmoil? This was a time of the SARS epidemic in Hong Kong, and tremendous economic turmoil. I don't know the answer to why a new method gets selected, but it happens over and over again. Here's unemployment statistics. The purple is the unemployment rate, the suicide rate is the darker blue. This has been shown over and over and over again since the early 1950s. What is it about economic circumstances? A paper came out in recent weeks, or a month and a half ago in the United States, about home foreclosures and suicide, even controlling for the unemployment rate. So this, again, is the kind of thing that we see as having, powerful, influential effects. So we need more innovative thinking about these patterns. There's just a whole world of I don't know. I said I don't know a lot, and there's a lot that I don't know. So more research is essential, but communities can't wait. Right? We can't wait another 10 or 15 or 20 years until we get all the answers. We have to figure out how do we do this. And so we have to use theory and available evidence and best understanding. But this is where it's going to become very important to rigorously measure your outcome. Now, if you were, and I'm going to start harping on this measurement thing again, if you were investing your money, would you ever invest where someone wouldn't show you what your return rate was? Would you ever spend your money and say, hey, go for it, and in 20 years come back and tell me whether you made a difference? you know, you look at the person and think, well, this is really weird. I would do a thing. And that's what we've largely done with suicide. We throw some money at something. We say it makes sense, but then we really don't measure whether the outcomes are. Now, the outcomes could at first be, can I engage the populations I want to engage? I don't put much stock in saying I trained a whole bunch of people, because I really don't know if they did what I trained them to do. But I sure do want to know if I engaged the people I think were vulnerable. I sure would want to know if I got them into some sort of care. I sure would want to know if I made their suicide attempt less, or at least contributed to that, and obviously and ultimately reduce the suicide rate. But it's really hard to do this, because in the United States, there's been a lack of coordinated strategies that can deal with local, regional, state, national agencies and organizations. And this is really true despite even having another strategic plan. So, you know, we have a lot of political turmoil in the United States over recent years, and of course, one of the things that is most interesting to me is around all the discussion about Obamacare, is the issue that, of course, this is about the 10th Amendment to the Constitution. Right? The 10th Amendment says that, you know, all powers that are not, you know, given in the first 9 to the federal government go to the states. So there is no central health planning authority in the United States. None. CDC has no health planning power unless there's a national emergency around infectious disease or something of that sort. So in many states it devolves to this, you know, goes to the state. And in many states to the counties, depending on how the expenditures in the state constitution reads and the like. So when you say you want to put together a coordinated strategic plan for the state of North Carolina, I don't know the way North Carolina works, but I bet you at some level the state is going to be using moral authority and, what should I say, persuasion and good reason, but it's going to be the counties and the cities that get to play and carry out things or not. And how we build this is really critical, because if we don't build this kind of action, we may not succeed. The one place where it kind of worked was the Air Force. And it worked because the #2 general in the Air Force said, after reading over a bunch of records, this is unacceptable in the Air Force family that we have these suicides. And they threw everything they knew into this Air Force program. They didn't say it was medical, they said it was community, but they had the medical people, the public health people, their personnel, you know, like their HR department, command, law enforcement, legal, family advocacy, finance. I didn't have that on the list there. You know, they had financial counselors for all the people who dead, child abuse services, chaplains, some expertise from the outside. They changed everything they knew. It all eventually boiled down to about 4 big categories. And it was interesting because it turned out to be really more of a violence prevention program than a suicide prevention program. So not only did suicide go down by 1/3, but homicide went down by 1/2. So-called accidental death, that's the term they used, and I don't like accidental, but they used it, went down by 18%. Severe family violence went down by 54%, because that's one of the things they really targeted. Moderate family violence went down by 1/3. Mild family violence went up, as it should have, when they did a public health program to identify mild family violence before it got worse. They changed some of their policies, they changed some of their stuff about, you know, if you self-reported on your alcohol use, you could get treatment. Now, this program worked very effectively until about 2004, and then it started to spike up. And one of the things that I had said, Carrie Knox is the leader of our group, but I had said in a meeting with Carrie and what I call the 3 colonels, there was the colonel who was the first sort of chief of staff who organized this, and then his 2 successors. And it was in July 2002, and I said, how do you know that there are people who are doing this? And they said, well, because the generals ordered them to. And I chuckled. I said, how many installations do you have around the world? 78 or 79, depends how you count them. And I said, so you think just because some general somewhere in Washington said that you're going to do this, that everybody's doing it, and you've got a war in your hands now? And at that point, my nephew, who's been in the full-time Guard, is now in the part-time Air National Guard for many years, was over in Afghanistan and getting ready to go to Iraq in the Air National Guard. And I'm saying, you know, they're thinking about other things now. And so it's very clear that it spiked up. And so I said, you're not doing it. That was my one contribution on the conference call. And you know, Carrie was trying to be all politic and sensitive to her colleagues and saying, you're not doing it. And Colonel Wayne on the other end said, Wayne, I'll give his last name, says, no, I think we're doing it. I said, you're not doing it. You just go out and survey and we find out. So they went out and surveyed it. Guess what? They weren't doing it. They had got it. Actually, the Air Force has turnover. You know, you're in a position every 2 or 3 years, and you turn over. And so the generation that had been inculcated with this program had left, and the new generation was on war footing. They weren't paying attention to this. So they put the pressure on again to drop like a rock. But then later on it increased again. And they're working on it. So you've got to have structure. You must have community interests involved. The Air Force, whether they knew it or not, had everybody in the community involved. I remember, you know, for those of you who know about the culture of these places, my sister-in-law, as my brother got involved in a variety of things, and eventually he was a vice wing commander and an acting wing commander. My sister-in-law was always sort of the center of this informal community structure about the Air Force family. You know, when he was a squadron leader, or he was a wing, you know, weapons wing officer, or whatever it was, or wing weapons officer. You know, there were all these informal things going on. They always knew what was going on in the neighborhood. You know, so-and-so's kid was having a problem, you know, the family was in, you know, some violence, and they were coming together to support these folks. So community, it can't be underscored enough. Now, I'm a medical type, but this is not about medicine. This is about community and how does medicine, mental health, and other things fit in. And so it's a culture of safety. So I'm going to start drawing towards a conclusion, because I see the food starting to come in. Some of you are probably passed out already. I woke up, I was starting to get into my nap mode, but then I said, oh, I got to stand up here and talk something about. You know, suicide has many common features with other forms of premature death, depending on where you are in the life course. Homicide victims, homicide perpetrators actually too, who are youth-focused. Motor vehicle deaths, self-inflicted poisoning. We'll talk more about that in a moment. And so we can think about universal, selective, and indicated depending on where they are in this. Now we see the deaths up here, and I honestly don't know what makes them one versus the other. But I do know at the base they have many common risks. We don't stand together as communities to look at those common risks. What we do is we tend to look at the peaks because of our own life experiences, our own interests, who we've lost, what we've gone through. Medical examiners see people who went along that path and how they came to a particular death. I still venture to say I don't know, and I'm not sure that maybe our former medical examiner knows, but I suspect we all sometimes wonder. Now, one of the things that we're talking about, and this is a terminology that we've been working with someone named Ian Rocket at West Virginia University and others, is DDSI, or death-related or death due to drug self-intoxication. Now, some of suicide, right, is poison-related, death, overdose-related. But it's really a focus on the deliberate activity that leads to death. The question on the day you die, did you intend to die, even though you've been, you know, I use the Philip Seymour Hoffman example, for those of you who know the actor who grew up around Rochester, New York, a wonderful actor, an Academy Award winner who died in February of 2013. And of course, I don't think of these as accidents any more than I think of road traffic injury deaths as accidents. These are behaviors that increase the probability of an adverse outcome. And they're suitable for prevention programs. And this is really important because if we look at the surging rate of deaths in the United States from drug poisoning, we see that for both men and women, this is really, really stupendously, rapidly increasing burden. So there were, in 2013, slightly over 1,000 deaths in North Carolina from drug intoxication deaths. How many of those were just misdiagnosed? I'm putting misdiagnosed. suicides because there was insufficient information to make that determination. Well, that's one thing. But a major proportion of these deaths were actually people who had profound, deliberate, self-injurious behavior, which on a particular day killed them. Now, we may not call that suicide because we can't establish he wanted to die that day. He just did all those things. Or she did all those things. And again, like suicides, the burden is mostly in the middle years, and it is really driving this population. And I want to show you a slightly different slide. You are the first to see this in public. So Ian Rocket is working on this commentary that we're about to submit, and I said to Ian, you know, we've got to determine what the collective burden would be, and he showed it at a meeting where we were at in CDC, but then I said, how would it look if we did this over the last 15 years? What would it look like? So this is undetermined causes of self-poisoning. So it's poisoning, but it doesn't involve, the medical examiner says, I don't know. This is so-called accidental, and this is suicide. These two lines represent different guesses at how much of the so-called accidental self-poisoning or drug intoxication deaths were in fact deliberate in their behaviors, so they were DDSI. And what you can see is either with these estimates, either one of these estimates, there's just a little bit apart. This premature death due to self-inflicted injury is actually the 8th leading cause of death in our estimate, not the 10th. And I would argue that the prevention efforts, are much the same. And that's part of what we have to think about as we talk about community approaches. So I'm going to start concluding with Haddon, right? Haddon was a person who talked about motor vehicle injury. I steal from, I'll take from cardiology and Rose, I'll take from Haddon. And Haddon had something called Haddon's matrix for accident, then saying, it's not an accident, it's an injury. It's predictable, and I'm going to make up this matrix, and here, individual behavior, agent, physical environment, social and economic environment. So this is a Haddon's matrix for suicide attempts. Pre-event, event, and post-event. And so you can do the same kind of methodology that Haddon used, or that I'm sure that Patricia Waller used for motor injury deaths, in the same way that we talk about suicide. So it's very important to understand that, here's Pat Waller many years ago arguing for a public health approach to so-called road accidents. It's not different. This is a way of integrating individual, family, community, and society into an ecological model, right? A Venn diagram sort of thing. And you can actually take the risk model and turn it around and actually make an intervention model, which uses exactly the same formatting. And I'm going to put these up quickly. And if you're a community person and you want to say, yes, I want to have a suicide prevention program, I would ask you to fulfill certain what I call framing questions. What were the broad goals and specific objectives? Where's the piece that I want to, the program I want to put, where does it fit in the schema of this overall view? You're doing now a strategic plan. Well, what's the overall view of what it takes to get from here to here, I should say here to here, to make the suicide rate go down, or the suicide and drug poisoning self-inflicted rate to go down in North Carolina? What's the overall theory? What's the overall approach? Who do you expect to reach? Who will you reach with these interventions? Who will you miss? What are the sample biases of the place? What will I be changing? Or what will we be changing? And of course, then, I'm going to and how do we measure those changes? Because if you don't measure it, you won't know. Can we be confident in our findings? A lot of public health stuff, you do it, and then, you find out that someone else, can't reproduce it. Can it be exported? Can it be sustained when the originators So, this is many of you have the state report. These are your first 6 rank-ordered objectives, where you put importance and feasibility. Now, these include encourage community-based settings to implement effective programs, develop training, improve and expand state, territorial, tribal, local public health capacity, adopt, disseminate, and implement, promote timely assessment, integrate suicide prevention into values, cultures, and leadership, and so on. So, I'm going to say to you, as I would say to myself or anyone else, how are you going to measure it? But first, where does it fit into the overall schema? What do you propose to change? How are you going to measure it? How are you going to follow it? How are you going to hold yourself accountable? It's about accountability. It's about that return on investment in terms of fewer suicide attempts, or better lives, or more importantly care, or lower suicide rate. It's about those measurable things that you say, I really made a difference in people's lives. Where the public health and the clinical approaches come together, for me, for the department that I lead, for the activities that I do in the public health area, is have we made a difference in people's lives? Have we made a difference in the patient, if it's clinical, family, community, or region? Can we measure that in a way which someone else will believe that I actually did that? So, I'm going to come to the end here. Data, 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 data. Evaluate with data, data, data. So thank you very much.